So let's talk a little bit about how quality of life impacts skin disease. So if I ask you to think, what is quality of life? How would you determine your own quality of life? Whether you've got a skin disease or not, whether you've got a medical issue or not, how do you determine your quality of life? I like to think back to, and I don't like to think back to it, but I like to link people's memories back to this whole episode with COVID and the COVID-19 era. All of us remember it for various reasons. But I personally, I've been blessed and fortunate not to have a skin disease. I have other health problems, probably, yes. But with regards to skin disease, it has a real impact on various aspects of people's lives. And when you go back to COVID, think about how that whole period affected your own life. How did it affect your relationships? How did it affect your work life? Many people were made redundant, unfortunately. Many people couldn't do their business. Certain things did thrive, yes, in the during the COVID era, but a lot of people suffered in many ways. And I think for many people, it allowed them to really reflect on what matters in life. When I think back to it, the whole thing was, of course, really daunting. I was redeployed as a dermatologist, funny enough. For me, I made a decision to stay with my family at the time. It was really scary. People of ethnic minority in particular seemed to be affected the most. And it was like going to war, the way we were preparing in hospital. And then, going home and then not meeting friends, family, and it's a real first world problem, but essentially, things like eating out, not being able to do tourism or going for holidays, things which we take for granted, but we enjoy. These things really highlighted for me, actually, wow, quality of life is affecting all of us during this period of COVID. But for some people, that's their reality all the time, right? That is their reality with regards to their relationships, with their holidays, with work, and that's something we need to consider. So how do you define it? Well, how do you define quality of life? What are the things that actually determine someone's life and the quality they attribute to it? So one is, of course, economic status. People associate quality of life with financial well-being. That's, of course, something that drives a lot of people. Employment. Whether they're in a job or not determines whether they are actually happy in their life, whether they feel content. Relationships. Right. So being in a relationship, not being in a relationship, difficulties in a relationship, these things impact our quality of life. It can impact how we are in our mental health, how even our other day-to-day activities can be impacted by issues that are going on in our relationships. And we've all been there in various aspects. Our career goals. Does your skin problem, does it affect your career? And we'll see that it possibly can, in many ways. And I'll go in more detail when we discuss that. And what about your ambition? Your ambition for achieving certain things in life. And you'd be surprised that and we often probably don't think about this, but certain conditions can really impact how ambitious we are, or how ambitions are formed and how they are changed. When you believe you have a skin condition that has no cure, can you imagine how that actually alters and changes the way we want to live our lives and what we want to achieve? That's really important. Faith. So religion is one of the things. I'm from a Muslim background, and Ramadan's coming up, and often there's lots of talks, especially when Ramadan is around the corner. There's lots of talks, for example, about diabetes and general health pros and cons, and people ask questions about if they're fasting, how does it impact their other various health conditions? Can they take inhalers? Can they can they still take their insulin? And how should they take their insulin? All these sort of things come about. And then if you put it into context of skin disease, certain conditions, for example, with eczema, you have to be careful with washing your skin regularly, because too much washing can dry out your skin. And particularly in Ramadan, when people tend to pray more and they do ritualistic washing, that's something that comes up. How does that impact their ability to, for example, engage in worship acts? So religion is something that really impacts people's quality, how they define their quality of life. They may not care about anything else, for example. They may not care about wealth or other things, but the faith for them is really important. So, one person's ambition and someone else's relationship, someone else's career goals, someone else's faith, these things are very personal. So that poses an interesting question, because all of these things, and there are other things, your personality and expectations in life, all of these things can define and influence the definition of quality of life. And that then makes it very subjective. And the subjectivity of quality of life is what's really, really important. When you look at the World Health Organization, their definition of quality of life, they say it's a state of complete physical, mental, and social well-being. So it's not just the absence of disease and infirmity. So, if someone is fit and well, that's all, that's great. They may not have any disease or any sort of condition, but are there, what is their state of the physical state? Are they fit and healthy in terms of how they feel, their mental and social well-being, how they fit in the social norms in the society? That's the World Health Organization. But one of the definitions that I prefer, and is my favorite definition, is an individual's perception of their position in life. And it's not just their position in life, it's in the context of culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. So it's very much in the patient's hands, right? So, like I said, I was saying in the previous slide, someone might really value their career, someone might really value their faith, someone might really value some other hobby that they have. And I think it's really important to assess that in that context. That's really important. I remember seeing somebody with a really, really terrible skin condition, psoriasis, and for them, it was the ability to swim with their children. Like, that was the goal. The fact that they were able to do that after having treatment with biologics, for example, that was a life-changing moment for them, because they could finally experience something that they want to do for a very, very long time. Where someone who never swims, why would we use swimming as a standard? It doesn't make any sense. So it's a very personal definition in a way. And when you look at the impact on quality of life, there are three dimensions, right? There's the now, like, how is your life now? How is your life going to look like in the long term? And what is the family impact of that quality of life? And we'll talk about that. And then, all of these things, all of these implications, the now, the long term, and the family, they should really influence how we treat patients and how we then derive these health economic decisions, right? So it's really important to therefore understand these impact, this quality of life impact, so that we can measure it and then decide treatment management plans going forward. You think about how do you compare? And I'll ask you guys these questions. How do you compare someone with asthma versus someone with eczema versus someone with with Crohn's disease, with some sort of gut impairment? How do you compare which group of patients deserves the more expensive treatment? If you've got as we know with the issues with the NHS, they have a set pot of funding. How do you then decide which disease gets what funding? And that's all down to health economics. And that's not an easy decision to make. That's something that you have to consider various things, including the impact on their lives, and not just their lives, but the long term, the family, and the economic impact. If someone cannot go to work, how does that impact the country, the society in the long term? So we're going to use something as a case study. We'll use psoriasis, because I think psoriasis is a good demonstration of how life can be affected, not just for the patient, but for the family. And so I'll start with the basic clinical presentation of psoriasis. For those who are not familiar, psoriasis presents as a chronic plaque-like condition. So you can see the picture here is well defined, often on the extensor surfaces, usually the elbows, the knees, and you can get it pretty much all over. But it's classically on the extensor, compared to eczema, which tends to be not so well defined, and you get fissures and excoriations. Psoriasis can be itchy, and that's where the name comes from. Psora is a Greek term for itch, but it's not the defining feature. And actually, for many years, it was actually confused with leprosy. And again, that goes down to the whole social stigma, and which unfortunately still exists. It's only in the late 18th century when it was differentiated as Willen's lepra, and even then, maintained some sort of lepra link to the name. But we know now that psoriasis is a chronic immune-mediated and inflammatory skin condition, and you get these red scaly plaques. But unfortunately, people still think there's a infective element. You cannot catch psoriasis; it's not contagious, but that still exists. And people are, even though people are educated about it, and even patients, know, sometimes they feel conscious about that. The fact that other people might find it's contagious and might change how they feel or perceive their skin condition. And again, this is the classical areas: white scales, erythematous plaques, and you can also get real thick, scaly scalp involvement, which can be, have such an impact on patients' confidence, and it can also impact the nails as well as joints. It's essentially a worldwide phenomenon. We see it all over the world, but tends to be less so in for some reason, we don't see it as much in the Scandinavian countries, and of course in some of the Asian countries. But this could be largely due to lack of data and epidemiology. But it does exist. It exists all over the world. You have over 125 million people worldwide, both men and women. And it can affect any age. I've seen young children with it, and I've seen elderly in their 70s, 80s suffering with psoriasis. And in children, about 2% of children have it overall. But we do know that the incidence has been increasing over the last few decades, and it can present in many ways, right? So I know I mentioned the large plaques. You can see on the top left there, figure A. That's the standard presentation of chronic plaque psoriasis, but you can get a guttate version, as you can see in B, where they almost look like tiny raindrops. And then in C, you can get inverse psoriasis, where it can affect just underneath, the breast or the armpits or the groin, is what you know as inverse psoriasis. You can get a pustular variation, as shown in D, and you can get erythrodermic psoriasis, as you can see in E, which is widespread inflammatory psoriasis, and that's a dermatological emergency. And I appreciate we don't have many emergencies in dermatology, but there are quite, there are a few, and they can be life-threatening, and erythrodermic psoriasis is one of them. So how would we normally measure how severe it is, right? You can look at someone and say, wow, that looks really bad. To objectively do that we use something called the PASI, the Psoriasis Severity Index, Psoriasis Area Severity Index. We look at each area of the body, the head and neck, the trunk, the upper limbs, and the lower limbs, and we score how red it is, how scaly it is, and how thick it is. And that really helps you come to a score. There's some fancy formula that's used, and then if you have a score of over 10, it's severe. And it's actually quite easy to get severe psoriasis. But equally, imagine if someone has a huge patch on just their face. That person, would have such an impact on their life, but their severity, their clinical severity, is under 10, and that means that they're not severe. But actually, they might be suicidal. They might be depressed because of their psoriasis. That's an important point I want to highlight, that these clinical severity measures do not always capture how severe that psoriasis is for that person, how severe a skin condition is for that person. Because we know thankfully that's being recognized in psoriasis. We know people who have severe genital psoriasis, for example, they would even though their PASI would be under 10, i.e. not severe, but because it's in a place of high impact, the genitals, where it can affect intimacy and relationships and confidence, or on the face or scalp, it can, because of its visual nature and the fact that everyone can notice it. These things can actually make you qualify you for a more high-end treatment like biologics. But the other thing, with skin conditions in general, is that a lot of skin conditions do tend to have other comorbidities. Psoriasis, eczema, hidradenitis suppurativa. We're increasingly recognizing these are centrally inflammatory conditions. So there seems to be a central process at play here, and therefore there's lots of other things that can coexist. With psoriasis alone, you can get arthritis, obesity, cardiovascular disease, metabolic syndrome, which involves things like diabetes, COPD, sleep apnea, psychiatric illness, and then when you have all of that, it can also be associated with smoking and alcohol abuse. So what are we treating? Are we just treating sometimes we're pretty bad. And I have to say, as the NHS, we're pretty terrible at prevention and looking at root causes. We're very good at treatment, yes, but with all the pressures, we got to think of, what else can we do to get to root causes of these things? That's a separate point, but it's just something to consider. So how do you measure this quality of life? Right now, somebody comes and they say, look, I've got really bad skin condition. How do you then say, okay, well, how does that affect you? If you're in a clinical setting, you've got 10, 15 minutes, it's very difficult to actually ascertain how that person's life is being affected, because you don't have half an hour, an hour. Ideally, you do, right? I mean, if you go see someone privately, you'll have an hour, you'll have 30 minutes, 45 minutes. And ideally, that's what it should be in the NHS, but that's not the reality. How do you do it? So when you look at how to measure quality of life as a concept, there's something known as the patient-reported outcome measures, or PROMs. This is a report that comes directly from the patient. It's about their health or the health condition or the treatment without the clinician or anyone else interpreting it, right? So it's directly from the patient. They fill it out. They fill out this measure, and you can then tell how that condition affects them. And that could include things like symptoms, itchiness, burning, scratching. It could include functional status, like how does it impact their ability to function on a day-to-day basis. And it could be general, or, about their general health. So this is important. And actually, this became even more important with a pharma-led awareness of it, because now a lot of pharma-led interventions and trials are looking at the patient impact, because when something affects the patient's well-being, there more than just what something looks like, then actually, we should pay attention to that, because essentially that has a wider impact on treatment outcomes. There was something known as the RAND health insurance experiment a couple of years ago, and that looked at, imagine if you were to pay for your healthcare as well as the health insurance contribute. So if you're equally contributing to the cost of healthcare, then it was interestingly found that people tended to be a bit more conservative, and they found that people were a lot more careful with the sort of treatment options with healthcare. And anyway, that was quite an important study, but they used health outcomes on that, and that became a catalyst for including health outcomes in studies. So how do you do it? How do you measure? Because essentially this is a science, right? Measuring quality of life is actually a science. So you might think, okay, well, it's just a bunch of questions, but you need to ask the questions, the right questions, and they need to measure, they need to be applicable to everyone. And that's hard. That's really hard to do. And to be honest, there's no perfect measure. But when you ask the same question often enough, again and again, you will get the same answers. So that's essentially how quality of life measures have been developed. And what I'll talk about is one of the ones I'll mention is the Dermatology Quality of Life Index. Is the most commonly used questionnaire in dermatology. If you ask somebody, okay, tell me, how does skin affect you? How does your skin condition affect you? How does psoriasis affect you? They will say, oh, you know what? I can't go to work because I'm embarrassed. I don't have a relationship with my wife because it affects intimacy. Oh, I feel very embarrassed. I can't do sport. I used to love swimming. I can't go swimming. I used to love playing football, tennis. I can't do any of that because I can't wear shorts. I'm embarrassed. And if you ask enough people these questions, what you'll find is people are answering the same things over and over again. Eventually, you'll have a huge bank of answers where after a certain period, you're just not getting new answers anymore. You're not getting anything new in terms of new impact on people's lives. And when you look at that, and when you aggregate all of that, you can get a set of questions which are relevant for a particular condition. And then if we look at actually, when you look at how quality of life has instruments in psoriasis have been used in trials, you can see they've been increasing generally. So it's becoming more and more relevant. We know that asking patients that question is extremely relevant. And there are different types of measures. There's general ones, and there's a list here. General basically means, okay, how's your general health? How much anxiety do you have? How much depression do you have? Are you able to look after yourself? These are general questions. And that's good because it covers lots of conditions, but it's not so good because it's not specific to a condition. And then you can, as you see with the arrow, you're getting more and more specific. You can get dermatology specific questionnaires, so questions that are applicable to any skin condition. And then you get even more specific. These are disease specific questionnaires. So questions that are specific for psoriasis or for eczema. There are pros and cons of each of these. I mean, it'll go beyond. I'll bore you guys if I go into the detailed depth of that. But there are pros and cons. But the general argument is the more specific it is for a condition, the more representative it is of that patient's experience. That makes sense, right? It's like when you call somebody up and you say, hey, you call up a friend, how you doing? How's life? Great. But if you say if you ask your friend, oh, how's that project you were working on? It shows that you care. It's very specific to that person, and they'll be a lot more responsive. And it's very similar. That sort of thing works in the quality of life world as well. And the one I'm going to highlight is the Dermatology Life Quality Index. And I've been working with the department that developed this questionnaire for the last 11 years, 12 years or so actually. And it was developed in 1994, so almost 30 years old. By Professor Finley, who's this gentleman here, who I still work very closely with, and is the most commonly used questionnaire in dermatology. It's been translated in over 100 languages, and it takes 2 minutes to complete. So you can give this to a patient in a consultation, or even better, we've got an app now. It's called the DLQI app. You guys can download it. Patients can complete it before, and you just write it down. It's out of 30. 30 out of 30 means you've got the worst quality of life. If you score 0, well, your quality of life's okay. And it asks you how your skin condition has affected your life over the last week. We validated it electronically. So like I said, you can do it on an app. No measure is perfect. And this has been criticized because, is there enough representation about your emotional impact? You can see here, there's 10 questions. And there's a section here that says not relevant. So for example, if I draw your attention to number 6, over the last week, how much has your skin made it difficult for you to do any sport? And if you click not relevant, then basically that scores 0, which means actually it doesn't affect you. It doesn't affect, you doing sport. It's the same as clicking not at all. And that's a criticism, because actually if someone's skin is so bad that they've never done any sport, they might click not relevant, but actually that's a significant effect, isn't it? So that's a criticism of the DLQI, but despite that, it's quite a solid measure. It's been validated extensively. It's been used by millions of patients across the world, thousands and thousands of studies, and actually it only takes less than 2 minutes to complete. Great. There's a children's version for it as well that can be used for age 4 to 16. And there's a cartoon version as well for even younger children. And parents can help children fill that out, And that's important, because you think about innocent little children, who suffer with really bad eczema. Just today in clinic, I saw a young girl who has really bad eczema. And it was so bad that she scratches, especially in the private areas at night. And can you imagine when she shows up with sort of stains on underwear with blood and things like that, and she shows up to school, and that's very difficult for parents to explain, and it's very embarrassing. It can raise lots of concerns from a social perspective, from a social services perspective. Things like that happen, and so it's really important to identify that impact on that child. And this is a psoriasis specific one, so more specific to psoriasis. And let's look at psoriasis then. So, how does psoriasis affect day-to-day life? There's a study here which looked at psoriasis in terms of emotional well-being. 88% patients with psoriasis have an effect on their emotional well-being. 94% say that psoriasis is a problem in their daily life, and 82% say that psoriasis interferes with enjoyment in their life. And that's huge. Can you imagine living with something like psoriasis, where just think about waking up and choosing what to wear. People with psoriasis, for example, they can't wear, and they prefer not to wear darker clothes. Why? Because if they've got psoriasis on the scalp, the flakes fall off and it shows, so it's more obvious. They never wear or they don't like wearing short sleeves or shorts because they don't want, or skirts because they don't want to show the rest of their skin, so they're always covered even in the heat of the summer. So every second of their life is psoriasis interferes with it. And we look at the individual aspects. So if you look at psychological issues, for example, at least 75% say they have a negative impact on from the psoriasis on the quality of life. A fifth of patients with psoriasis contemplate suicide. I mean, that's a huge amount. I mean, that, 20% is, is significant. And they're more likely to depress. They have this feeling of hopelessness, and they're concerned because of future plans due to outbreaks. I've seen many people who come to me in the clinic, they're about to get married, and they say, look, I just want my skin clear for my big day. Many people are privileged where they don't have to worry about something like that, and just worry about centerpieces. People are worried about how they'll appear, and how they'll be perceived, and the worst thing is not just with psoriasis, but even with eczema, you just don't know how it's going to affect your future plans. If you're planning a holiday, it could completely ruin your holiday. You could end up in bed because you've got infection in your eczema, and you've booked this expensive cruise you've been planning for a whole year, and suddenly you cannot go on, you can't enjoy it because you've now suddenly got an effective exacerbation of your eczema. And a lot of people feel like they have no control, and I think we can all identify with that in some way. We all have plans, we set deadlines if you want to do work, or if you want to achieve a certain career goal. We have at least some control over how we can contribute. But people with psoriasis and skin issues feel like they have no control. There's this feeling of humiliation, swimming, intimacy, you've mentioned, feeling of that the public and the physicians, we don't understand the impact, and so counseling is important. There are clinics now. They're called So Well clinics, where they have a psychologist as well as a dermatologist, and that's brilliant. You're assessing not just how something looks, but how it makes you feel, and that's so important. And just look at the emotional and physical impact of psoriasis. Self-consciousness, unsightly appearance, anger, frustration, concealment with clothing, disfigurement, itchiness, physical irritation, pain. We're looking at, yes, is the red. So we're looking at most of these patients with psoriasis experience at least, if not all, but some of these symptoms. And what about work? And I think we can all identify with that. We come from, a lot of us come from medical backgrounds. I see patients who come with psoriasis. I just met a lad last week who was worried because he works in healthcare and is going to be immunosuppressed. But equally, what about people who have severe psoriasis? 2/3 miss 26 days because of psoriasis, a month. And can you imagine the pressure that puts on them and on employers and the whole unpleasant situation? And 35%, a third, report reduced earning potential. So all of this creates a financial burden. Why? Because they're not going to work, and then there's the cost of disease care. What does that mean? If they're not going to work, what does that also mean? That means they're staying at home. That means I appreciate, we don't think about this. That means they probably have to have the heating on in the house when they're in the house. They've got to start eating, maybe more groceries, in the house, or the cost associated with extra care that they need to do, washing, changing clothes. If they've got children, looking after children, all of these, they add up, and so it's not just about them missing work, but it's about what comes with that, and the loss of productivity, career prospects. What about the child who's got hand eczema, who wanted to be a surgeon and says, I can never be a surgeon because my hand eczema is so bad, I can't ever imagine showing my hands and operating. Maybe patients will feel uncomfortable if I'm touching them with hands that have got eczema. And that's really sad, right? People are changing their entire careers. Maybe they want to be an artist, but they can't because they've got an allergy to certain aspects. They've got a contact allergy to something. I've seen people who work in banks and they're allergic to nickel and coins. So, they physically can't handle coins in the bank, or security guards, they tend to hold their keys in their hands. And so they develop contact allergy to keys. So, all of these things, work it's comparable to other chronic diseases. People don't notice that. And often, unfortunately, dermatology gets pushed to the back of the list because they think, it's not dangerous, it's not going to kill them. But what is the real impact? And it's huge. And if you look at their work life, It can affect the education, and these are both looking at men and women, looking at the limitations in work, limitations in job status, skills. A lot of patients, a fifth of patients are forced to quit their job, and they feel they're treated differently because of their skin problem. So there's lots of stigma associated with it. So we looked at psychological, we've looked at work, but what about social, right? People start developing maladaptive coping responses. What does that mean? They might start, taking up other habits like smoking or alcohol. And actually, that's terrible for the patient because it can lead them into a vicious cycle. Alcohol, smoking, these things, and junk food, these things actually can exacerbate psoriasis. A poor diet and all of these things. These can all make psoriasis worse, and you end up. What happens? You end up looking worse, feeling worse, and then that perpetuates this body image, self-esteem cycle, which can really, really impact patients. And it can, what does that mean? It results in shame, embarrassment, and feelings of stigma about their appearance. And then what happens is they don't want to discuss their condition. Right? They're just fed up of people always asking, oh gosh, what's that on your face? What's that on your hand? And people feel absolutely aware that no one wants to touch them. And so, they avoid contact with people overall because they just don't want that stress. They don't want that negative impact on their life. And then again, having to reiterate, this is not contagious. Psoriasis is not contagious, and they have to keep doing that. But equally, when they there's lots of studies that show that actually when they do talk about it, and when other people also share and empathy, can actually help their quality of life, and it can reduce that. So equally, having that conversation and making a safe space for the conversation can be helpful. And I'm going to finish, hopefully in the next 5 minutes or so, 5-10 minutes, about this concept called the greater patient. So I'm not sure if you guys heard about this, right? So here, if you've got the patient in the center and who's around that patient, and that's what's known as the greater patient. This is the immediate close social group affected by that person having a disease. So if someone has a disease, how does that affect the partner? How does that affect their children or sibling or parents? That is another question. Do we have time? No one has time to go through that in 10, 15 minutes, but it's something that's so important because we'll see. There are certain measures we've recently developed as well in Cardiff University, where you have a measure that asks the family, how does your family member's condition affect you, right? So imagine you see somebody who comes into your clinic. It's it's a woman with psoriasis. You would then ask the husband. You give that questionnaire to the husband and say, how are you affected by your wife's thing? And why is that important? Well, because let's see, impact of psoriasis, for example, on parents. Imagine you've got a child with psoriasis. What does that mean? It means you got to look after that child all the time. You're worried about that child all the time. If your child is ill and you have to stay home with the child, well, that affects your ability to go out and earn money. It affects your hobbies and things like that as a parent, because you might have to change that according to what your child needs. Sadness, frustration, depression, emotional well-being, stress. It can then affect the couple. So if you've got a couple with children and the child needs constant attention, the couple are not able to share a bed at night. They have to separate out. It affects their sleep. And that concern about that child can really take a toll on parents. And even in the family, the wider relatives, again, I won't go into detail here, but you can just see that, so many different aspects of it. Holidays, family holidays. And that's not just psoriasis, but with any condition, you have to think about it. If someone has allergies, you have to change how you, for example, right, how you travel, for example, and that for that family, it makes it very difficult. You have to consider health insurance when you travel. What about housework and daily activities? Do you know, like patients with psoriasis spend a lot more time doing housework because they have to, you think about all the flaking that happens. And so they have to clean the house, do the vacuum cleaning, changing bed sheets with patients, for example, if they've got blood on the sheets, they have to do it regularly. And imagine if you're in a relationship, that's quite embarrassing waking up with, for patients when they wake up with blood and flakes on the sheet. So these all sort of things, can make a huge impact. And the other thing, dermatologists are notorious for giving topical treatments. We give a lot of moisturizers, But I'm very conscious when I give moisturizers to patients, I know what that means. And I don't know whether all of you have ever considered that, but giving moisturizers to someone who's got eczema or psoriasis all over their body is actually, meaning that you are giving them a prescription for sitting at night, taking literally 1 or 2 hours of their life where they put this greasy stuff all over their bodies, arms, legs, torso, and they sit there with it soaking. They can't, is getting greased all over their sofas, over their bed sheets, and they have to do that 3-4 times a day sometimes. And then they have to go into work, and they can't. A lot of them just simply cannot cope with that. And so that makes an argument for, should these patients be on the highest end treatment straight away? The NHS has a ladder. You got to try the topical moisturizers, steroid treatments, then immunosuppressants, and then the biologics. I mean, there's an argument. I personally, if I could make an argument, I'd say all of these patients should be on the best treatment possible straight away. But that's how it works. Siblings have a similar impact. If someone has eczema, studies show that siblings can have a similar impact on their quality of life as that person. Who suffers with eczema or psoriasis. They can have increased exhaustion because they're maybe sleeping in the same room. Or what about the impact on their relationship with their parents? Because they're like, oh no, my parents are spending so much time with this other person, with my other brother or sister, they don't spend any time with me. I'm getting really attention deprived as a result. So there's a huge question. And, recently a patient said it was an interesting question. They were really happy. It's the first time they've been asked about the impact of my wife's psoriasis in 22 years. And so, it's really interesting. There's so many factors to consider when you consider quality of life and the impact of quality of life. But the problem is, how do you then compress this into clinical practice? How do you compress this into research? But there are some positives, right? I mean, can skin disease have a positive impact on quality of life? It can do, because, often patients report that they can have a strengthened bond with their children, for example, because they spend extra time treating them, supervising them. It creates that bonding. And interestingly, have you thought, when children are scratching, what do parents do? They hold their child and they hold them even closer. And actually, studies show this creates a deeper emotional closeness. I've done that with my own children. When they're ill or unwell, you hold the child, and that's a moment of bonding that unexpectedly gets you closer, despite a child suffering. So there are some positive impacts from these things that we know. But also, when you look at skin conditions, parents feel empowered by learning about things like eczema and educating others. And studies have shown that actually, when patients are empowered that way, that makes them feel better, because they're making a difference and they're helping others. So there are some positives that can come out from that you can sort of take from these things. So I mean, I'd really just complete this. There's a whirlwind over quality of life impact, and I just really, my goal with these sort of things is to make people empathetic, having sympathy and empathy for patients who come through the door with skin conditions, because it's not just about how it looks, it's about how it makes you feel. It really is. It's not just visual measurement. It's not just like, oh, look at that, it's only a small patch on your face, that's fine, I'll discharge you back to your GP. But that small patch on the face might make someone suicidal or depressed. It might have a real impact. It might be in a very sensitive area. And so we need to measure our quality of life so we can see how we can treat that burden of skin disease. And that's why these questionnaires are excellent. It's a science that's huge and is hugely growing, and it's a real science. Testing whether questions measure what they're meant to measure and is repeated and tested over and over again. It's a real science, and it's about having questionnaires that are more generic, that might apply to everyone, or more specific. And that depends on individual person and individual use and the type of study or clinical scenario you're faced with. And if you understand this, you're better then equipped to look at the economic impact of a skin condition. And you can look at how we can then, that child with eczema, because we know he wants to be a surgeon, he wants to be an artist, he wants to use his hands, he wants to do something physical, is there an argument that we can expedite this person's treatment? Forget creams and things like that. Let's give the best treatment available. Is there an argument for that? And remember, the greater patient is also the greater therapist. Why? Because if you have a whole family. Often, one of the things for me to know whether something really impacts the patient is when a whole family shows up in clinic. Often if I've got a patient by themselves versus a patient with their mother, father, sibling, all in the same room, that tells me, wow, these guys, they all care. They all care. What does that mean? It means you're not treating just the patient, you're treating that family. And so that family can also have that potential to be a therapist for that patient. So, sometimes I look at not just the patient, I speak to the family as well. As long as the patient's happy. I mean, by default, the patients coming in with family means they consent everyone being in the room and to be involved in decision making. But sometimes it's really important to ask. And I often just drop in a single line. So, for example, if it's a parent, I say, "Oh, that must be really hard for you, and it must affect your sleep. It must cause a lot of stress. And I'm sorry you're going through that. But let's work through it together. Let's make sure that all of us are able to give the best for that patient, so that it's the best for you, or for you as a family overall as well. Let's look after you as well." And it's not a huge thing. It just takes a couple of sentences, a couple of seconds, really, to make that statement, and makes a huge difference for the whole family, and not just the patient. And so I think there's a real need for developing this quality of life science. Why? Because it just means that we are able to improve the whole process of managing the patients and getting really to the bottom of what really matters to them. So that brings me to the end of it. Of course, thank you for listening. I hope that was informative, at least open your eyes to how skin disease can affect people's quality of life. And of course, if there are any questions, I'll be happy to take them. And I'll just leave you on this Synapse Instagram QR code, where you can take and follow them for further talks. And equally, you can join this WhatsApp group for medical and dental students. I'll leave that on the screen. If there's any questions, I'm happy to take them. Thank you.